Good afternoon. I am Rich Hamdi. I'm a pediatric orthopedic surgeon in Montreal at McGill University and the Shriners and Montreal Children's Hospital. And first, I would like to thank Professor Hemant Sharma and the organizing committee of the whole course for having invited me. It's always a pleasure to participate in that course. Hopefully next year it will be an in-person course. Today, I'm going to talk about deformity correction in patients with complex and metabolic condition, specifically skeletal dysplasia, rickets, fibrous dysplasia, and osteogenesis imperfecta. I have no disclosure. First objective of this talk is to answer the question, why deformity correction in patients with skeletal dysplasia and metabolic condition is different and more challenging than other conditions. Then what are the characteristics of these deformities that make them so different? And what are the presently available options for the management of this deformity? And then we'll go through some examples. Skeletal dysplasia means that there is a generalized structure abnormality of bone and cartilage growth and modeling. The vast majority of these cases are hereditary. We should be suspicious of skeletal dysplasia whenever a patient presents with the 4 Ds: dwarfism, dysmorphic features, disproportionate features, and deformities. And as you can see, deformities is only part of the condition. There are about 450 cases of skeletal conditions causing skeletal dysplasia, and now there is even much more. And the spectrum extends from the lethal dysplasia at birth to normal persons with early onset arthritis. We are going to go now through the characteristics of the deformities in skeletal dysplasia that are very important to identify during the planning of deformity correction. The first one is the presence of short limbs, which may be disproportionate. Many skeletal dysplasia are dwarfs. And as you can see here, this is a patient with achondroplasia, very short and fat limbs. Extremely important when you plan to correct the deformity with a circular external fixator to measure accurately for the size of the rings and the distance between the rings, so that it allows for the distractors or the struts to be placed. The second characteristic is that usually the deformity is present with multiple problems other than the long bone deformities. For example, we have this patient, 14-year-old with multiple epiphyseal dysplasia. She has a deformity of the whole left lower limb. However, there is also a dislocated hip, there is a valgus of the distal tibia, and there is a scoliosis. So a careful, complete musculoskeletal exam, and in fact a general exam, is really warranted in all these conditions, not to miss any other deformity. Of course, C-spine anomaly is extremely important. In fact, any patient with skeletal dysplasia has a C-spine abnormality until proven otherwise. The third characteristic is that these deformities are not simple uniplanar one. They are complex deformities, often bilateral. They are multi-apical, multiplanar, multi-segmental, and may be associated with ligamentous laxity. This is a typical example of an achondroplasia presenting with Genu varum. And after analysis of this deformity, you can notice that there is both a bony and a ligamentous component. Bony, there are more than one segment. So there is a distal femur deformity, proximal tibia and distal tibia. There is also ligamentous laxity of the knee that really compounds the effect of the Genu varum. So that's a typical example of a multi-segmental, multi-apical, multi-planar deformity. This patient, achondroplasia Genu varum, that you can see here, and you can see here the X-rays. All the deformity comes from ligamentous laxity. Very, very important to recognize this laxity so that we don't go and then start doing osteotomies on the bone. The next characteristic is that the structure of the bone is abnormal. And this abnormality may be localized or it can be generalized. For example, this patient has osteogenesis imperfecta. We're going to go more in detail this in the second part, but this patient presents with a generalized bony abnormality. On the other hand, there are certain conditions who may have only localized abnormality. This is multiple enchondromatosis, and you can see the proximal and the distal part of the bone are affected. The next characteristic is that the anatomy of the soft tissues may also be abnormal, and because of this, the anatomy is disturbed, and there is higher incidence of nerve injury after correction of deformities in these patients. Many patients have intra-articular pathology. For example, this patient has multiple epiphyseal dysplasia, and it's very important to recognize this because the prognosis for the articular cartilage is guarded, and this patient may end up with early degenerative arthritis. Next characteristic is that in cases where two bones are involved, especially in the forearm and the leg, there may be asymmetric growth of the various bone. For example, here the ulna is shorter than the radius, and here the fibula is shorter than the tibia. And these may lead to severe deformities if left untreated and unnoticed. Then we have recurrence of deformity. This must be recognized, must be explained to the parents and to the patient. And finally, we mentioned C-spine instability, extremely important to clear before any procedure is performed. Next thing now, before we go into the example, how to correct these deformities. Well, you have several options. Can be corrected acutely by osteotomies or by fixator-assisted acute correction with nails and plates. Gradual correction, growth modulation, if the patient is clinically mature, external fixators. Also, there are some indications for this. And this is the internal lengthening device that can be used for correction of deformity acutely and then lengthening. And then you can have a combination of acute and gradual correction. The disadvantage of the acute correction is that it may need resection of large segments of bone to obtain satisfactory alignment and accommodate for the long-standing soft tissue contracture. An example here you can see on the X-ray, that's a fixed rigid equinus deformity. To obtain an acute correction, you have to resect a large amount of bone. The second disadvantage of an acute correction is the stretch of the neurovascular bundles. Also, in multiplanar and multi-apical deformity correction may be less accurate than the use of gradual correction with external fixator. Growth modulation is used extensively in pediatric orthopedics and used extensively specifically for correction of deformities in the skeletally immature. Can you use it in skeletal dysplasia? The answer is yes, but in less efficient, less effective than other idiopathic deformity. Should be done early. We can use 2 plates or quadrilateral plates, and the rebound is completely unpredictable. This is, for example, in growth modulation, severe valgus deformity that can be corrected with the use of double plates. So the first case that we'll go through is planning, extremely important. We'll go through this example. 13-year-old girl, multiple epiphyseal dysplasia, has difficulty and pain walking, wearing shoes or braces. On examinations, she has multiple deformity. She has a total LLD of 6 centimeters. On the right side, there is a valgus of the left disc of the femur, LLD of 2 centimeters. On the right tibia, there is an LLD of 4 centimeters and the valgus of the distal tibia. She has a severe equinus deformity on the right side. On the left, there is a valgus malalignment and the left distal tibial valgus. So how to proceed? You have to plan on the sequence of event of correction. And here is one example. The first thing, there is the mechanical alignment of the whole lower limbs. Both are in valgus. So a medial hemi-epiphysiodesis of the distal femur carried out on both sides. The second thing, at the same time as we do this, the deformity and the LLD on the right tibia to be corrected with a hexapod frame or in fact any type of frame. Then we have the deformity, the severe equinus deformity on the right side that needs to be corrected also at the same time as you lengthen the tibia. In that case, it was decided to proceed with a gradual correction so as not to resect a large amount of bone. Midfoot osteotomy was performed, and then application of a standard laser fixator and correction through the osteotomy. You can see here that's the TSF for the tibia, and that's the laser for the foot. That satisfactory correction was obtained, and that's removal of the fixator. So this whole planning is extremely important. We went from this to this correction of the equinus of the foot, and at the same time we had to lengthen and correct the tibia. The second case is, can we lengthen and correct deformity through pathological bone? And the answer is yes. There are many articles that have reported this. Here we have an example of a multiple achondromatosis, and you can see affect the proximal and the distal part of the femur. It was decided to lengthen the femur, so a uniplanar fixator was applied. As you can see here, the pins go through pathological bone in the proximal and the distal part, and a perfect regenerate was obtained. The third and fourth case explain Genu varum and Genu valgum deformities, and the option that you have to correct this. Either an acute correction with or without fixator, gradual correction through growth modulation, or gradual correction with external fixator. And you are going to see the various factors that help us decide which option to choose. So this is 7-year-old with severe Genu valgum, Morkier syndrome. You can see here the severe deformities in the around the knee, application of the 8 plate, failure of the 8 plate to correct. Then we proceeded with the application of a TSF and gradual correction. Second patient, Spondylo, metaphyseal dysplasia. And in this case, you can see here how the metaphyseal part of the bone is completely abnormal. And obviously this was judged that we cannot put 8 plate in this condition, and we cannot put also external fixators. Therefore, it was decided to proceed with an acute correction and fixation with KY. Therefore, we can see from this that there are several factors that really help us decide which option to take. There is the age of the patient, there is the severity of the deformity, there is the anatomy and the structure of the bone. All these play an important role in this decision making. The fifth example that we have is Achondroplasia with a Genu varum deformity. As you have seen, this Genu varum deformity can be caused by ligamentous laxity, bony deformity, or both. Here is a child with severe Genu varum deformity. However, we can see from here that it fully corrects by realigning the limb. This means that all the deformity comes from ligaments and not bones. Therefore, we should be careful that if you want to correct this, we should correct the ligamentous laxity and not any deformity, that bony deformity that really does not exist. However, this is another patient with achondroplasia and bilateral Genu varum. You can see here the deformity. That's the X-ray we have seen before. This comes from a combination of bony and ligamentous laxity. This can be corrected in several ways. We can correct this acutely by performing 2 osteotomies. Here you can see that there are 2 cores here, one proximal and one distally. So this, we can have an acute correction with a perfect realignment, or we can use a gradual correction using an external fixator. And really the choice of here the fixator depends on the experience of the surgeon. The take-home message regarding deformity correction is skeletal dysplasia. First thing is planning, planning, and planning, and this cannot be overemphasized. Expect recurrence of the deformities. Talk and explain to the patient and the family everything. Don't forget C-spine instability. C-spine has to be cleared before proceeding with anything, and there is no cookbook. However, you should be aware of all the modalities, of all the options that you have before embarking on correction of these deformities. The second part of our talk, it's on the metabolic bone disorders that cause also very specific types of deformities. All generalized metabolic bone disorders are generalized systemic disorders due to defect in bone metabolism. It's very important to realize here that all the bones of the skeleton are affected. All the segments of the bone are usually affected, and that include diaphysis, metaphysis. Therefore, intramedullary nails are the standard method for stabilizing fractures and osteotomies and in the deformity correction. The limb deformities are secondary to the medical condition, and therefore always start with the medical treatment and then address the deformities. However, in some cases, with severe disabling deformity or progression of the deformities despite medical treatment, then surgical intervention is indicated. And in skeletally immature patients, gross modulation with 8 plates has largely replaced the use of osteotomies for deformity correction. We are going to talk about rickets, fibrous dysplasia, and osteogenesis imperfecta. The deformities in the metabolic bone disorders are mostly essentially the same as in skeletal dysplasia. They are multiplanar, multi-apical, multi-segmental, usually they are bilateral, they are progressive, and with a high recurrence rate. The deformity correction here, first the condition has to be stabilized medically, and then we proceed with any surgical intervention that may include gross modulation, acute correction. Usually we use in the acute correction intramedullary nails. We usually never use plates. Gradual correction may be indicated in some cases of complex deformities and very severe deformities where acute correction may jeopardize our neurovascular status. I have examples now. This is a patient, 18 months old, first visit. He has hypophosphatemic rickets, no treatment, and the mother is very worried about his legs. Here you can see the typical radiological changes of hypophosphatemic rickets. So what to do? Well, start with the medical treatment. That we started here, the medical treatment, some improvement, more improvement, more and more improvement. Therefore, again, medical treatment first and then surgical treatment. Genu valgum can also occur in hypophosphatemic rickets. Medical treatment was started, however, condition got worse. Therefore, at that stage, you interfere surgically. 8 plates were inserted. Correction was achieved. Overcorrection, removal of the metaphyseal screws, some rebound, and the correction was almost perfect. Very nice. So again, start with medical treatment. If it fails, then proceed with 8-plate modulation. Be careful about the rebound. Another case now, and that's from John Birch in the Atlas. We have a windswept deformity in rickets. What to do? Well, medical treatment. Medical treatment did not correct the deformity. You proceed with plate modulation. It does not correct the deformity. Then we proceed with an acute correction, fixator assisted, and an intramedullary nail. That's a case from Turkey, from the Atlas also, an adult patient with severe deformities. In that case, I think it's too much severity to allow for anything except an acute correction. You can obviously try a gradual correction with fixator. In that case, acute correction using intramedullary nails. Here we see the use of interfering or blocking screws. Here we have nails to protect the femoral neck in both the femur and the tibia. And that is really the standard treatment in adults with severe deformity, acute correction with nails. As I mentioned, you can also use gradual correction with fixator. One word about fibrous dysplasia. Again, because of the whole bone is affected, therefore fracture and deformity are stabilized with intramedullary devices. Avoid the use of plates. Be careful about bleeding during surgery. They bleed a lot in the fibrous dysplasia. There may be delayed healing of the osteotomies. Realignment of the fracture and deformity is very important as remodeling is very poor. Bone grafts resolved, all of them resolved, even the cortical ones. Fibrous dysplasia bone remains dysplastic bone. There is no medical cure for this. Biphosphonates may be used for pain and sometimes denosumab. An example of monostotic type of fibrous dysplasia, you can see here the lesion in the diaphysis of the femur. Therefore, it was, you can see it here very nicely. It was decided to implant a solid nail, and here really it should have included the femoral neck also. Shepherd crook deformity is a severe deformity of the proximal femur, and generally speaking, if the neck shaft angle is 90 degrees or more, you can correct the deformity in one stage correction. However, if it's less than 90, then a two-stage correction is indicated. What does it mean this? You have here a severe coxa and shepherd crook deformity. First stage is the valgus osteotomy, and you have applied the fixed blade plate. Wait until this heals, and then proceed with the second stage, which is removal of that plate and insertion of a long nail and protection of the femoral neck. Then the last part of this talk would say a few words about osteogenesis imperfecta. It's also called brittle bone disorder, and it's anomaly of the collagen type 1 biosynthesis leading to several skeletal and non-skeletal manifestations. The treatment goal really in these children is to improve the mobility and function and improve the quality of life. How we can do this? We can improve the mobility and function by making the bone stronger by medical treatment and by making the bone straighter by surgical treatment rodding, and that's what interests us. The medical treatment, the standard is biphosphonates, and you have several types of biphosphonate. Now we are starting to use at a very young age in babies, in fact. The principle of the surgical management in OI, as I mentioned, it is use of intramedullary rods. And we'll go now, why do we have this rodding, when, which implants, and how? So the surgical treatment of deformities in OI, the first thing is what not to do. And what you should never do is the use of plates in OI. Why? Because it's the stress riser, and you will end up putting a longer and a longer and a longer plate. Therefore, the standard treatment is the use of intramedullary nail. No plates, no external fixator. Why do we rod the long bones? It maintains the bone straight during growth. It has, in fact, a tutor effect. It reduces the fracture rate, helps mobilization, and even when fractures occur, displacement is less severe. It's indicated now to rod all four bones, femur, tibia, humerus, and forearm. When is the time of rodding? As soon as a child pulls to stand, and that's between 18 to 24 months old. or when the patient has repeated fractures, severe deformities more than 20 or 30 degrees in the coronal or sagittal plane, or persistent pain due to microfractures. Which rods do you use? You have many rods. They can be regular rods such as K-wire, rush rods, William rod, elastic rod, telescoping rods such as the Dubobelli or Sheffield, Fassier Duval rod, and the sliding rod. This is an example of two sliding rods that we use. Telescoping rod, we have the Sheffield rod, has been described many years, still being used in some places, and it consists of a female inserted proximally and the male inserted through the knee joint. And then we have the Fassier Duval rod, which consists of male and the female. The female threads are threaded in the greater trunk, and the distal male threads are inserted distally in the epiphysis. And there is the male and the female sliding inside each other. That's the tibial rod. The same thing, the male threads are inserted in the distal tibial physis, and the proximal threads are inserted in the proximal tibia. What size of nail? Unlike solid intramedullary nails, we never put the largest nail. It may prevent bone formation. Therefore, the nail ideally should be load-sharing, but not load-bearing. Some innovations in the last few years, because of the Fassier Duval has no rotational stability, there are many authors now who are adding a small plate across the osteotomy site, a 2.7 screws with 3.2 plates to control the rotational component. There is the slim nail, which is a solid nail. The only difference between other types of solid nail is that here the presence of threads proximally with which we can thread this into the proximal epiphysis, therefore it prevents migration. We have the gap nail also, which is a solid nail, and it bridges the gap between the largest FD rod and the smallest solid intramedullary nail. 3D printing is used more and more, and here we have the 3D printing of a proximal femur deformity that is used in the planning pre-operatively. Percutaneous rodding is used as a minimally invasive type of surgery here to perform the osteotomies. A very important part of a component of the planning is how much bone should be resected to correct the deformity. In long-standing deformities like this, we have to resect some parts of the bone. Otherwise, we cannot correct the deformity, and it will be too much stretch on the soft tissue structures here, specifically the neurovascular bundle. And the resection of the bone really should be planned at the apex of the deformity. Should we insert the rods antegrade or retrograde? Both are viable option. I prefer retrograde insertion, however, both are possible. Here is an example of a proximal femoral deformity. You calculate where the cora is, so you draw here one axis, the second axis. If they meet outside the bone, this means that there are two coras here. Here are the two coras that are present, therefore this amount of bone is removed, and then the deformity is corrected. Fractures, it's the same thing. We have antegrade and retrograde insertion. It's very important to recognize that there is no remodeling after fracture, therefore they should be reduced as anatomically as possible. Here we have a fracture of the femur, and you can see it healed without any remodeling. One word about Coxa-Vara correction. There is a special technique very well reported and published. You introduce 2 K-wire into the femoral neck, and using this, you use it as a joystick to perform your valgus correction after you do an osteotomy here. You introduce your FD rod between these 2 K-wires, you obtain the desirable correction, and then you bend your K-wire and tension band. In that way, you protect the shaft with FD, and you protect the femoral neck with your K-wires, and that's the picture. Surgery and the biphosphonate, we have shown that delayed osteotomy healing can occur in OI patient after receiving pamindronate. Therefore, the protocol that we follow in Montreal is that no biphosphonates are administered in the first 4 months post-operatively. We perform one side at a time, the right femur and right tibia, and then after 1 or 2 weeks, we do the other side. 6 weeks post-rodding, the patients start partial to full weight bearing. Complications of rodding include many, about 50% complication rate within 5 years after the surgery. Bending rods, fracture of the rod, delayed and non-union, non-elongating rods, protrusion through the bones, and pulling through the distal epiphyses. Fractures femur are the most common cause of revision. Here we have an FD with a fracture and a bent rod. Other complication also can happen. Here you can see that there is a bent rod, non-union, protrusion through the cortex, non-telescoping, and pulling through the distal physes. The take-home messages really regarding deformities in children with osteogenesis imperfecta. Positioning during the surgery is very important. The pre-operative planning extremely important. Also, the type of the nail, the size of the nail. Do not insert the largest nail. Resection of bone extremely important. Use plates only as adjuncts. Anticipate complication and have a plan B and C ready if any intraoperative complication occurs. In OI, perfect is the enemy of good. Intensive and aggressive rehabilitation extremely, extremely important. And last thing, do not wait before deciding for revision. Thank you for your attention.